It is my pleasure to introduce Dr. Michael Grandner, who will give about a 40 to 45-minute presentation on sleep health and society, and then followed by a Q&A session. So we would love to have questions for that Q&A session, so please feel free to post them in the Q&A throughout the presentation, and then we'll have time at the end of the session to review them. So I'll move on to an introduction. Dr. Grandner probably doesn't need an introduction for most people. He's the director of the Sleep and Health Research Program at the University of Arizona and the director of the Behavioral Sleep Medicine Clinic at the Banner University Medical Center, and an associate professor in the Department of Psychiatry at the University of Arizona College of Medicine. His research focuses on how sleep and sleep-related behaviors are related to cardiovascular disease, diabetes, obesity, neurocognitive functioning, mental health, and longevity. He has published over 175 articles and chapters on issues related to sleep and health, and is the associate editor of the journal Sleep Health, and serves on the editorial boards of several other journals such as Sleep, Journal of Clinical Sleep Medicine, Behavioral Sleep Medicine, and a few more. He served on both the Mental Health Task Force and Interassociation Task Force for Sleep and Wellness for the National Collegiate Athletics Association, the Mental Health Consensus Committee for the International Olympic Committee, and works to improve sleep and performance in professional and non-professional athletes. He is a regular consultant on the topic of sleep health for organizations across the health, technology, and nutritional industries, and has helped found the Pennsylvania Sleep Society, served on its first board of directors, and is a past president. So Dr. Grandner is currently the president-elect of the Society of Behavioral Sleep Medicine. So with that introduction, I'm quite pleased to be able to pass it over to Dr. Grandner to share his slides and begin the presentation with a land acknowledgement.
Awesome. I thank you for that really kind introduction. Unfortunately, I think I wrote that a little bit ago, and now I'm the past president of SBSM instead of incoming. But the rest of that was really kind. I really appreciate the invitation and the opportunity to speak with you guys. As always, I have too many slides, so I'm going to go through some stuff quicker than others, but mostly for the recording. So if people want to stop and pick up some citations on anything, that's fine. And hopefully there'll be enough time for questions at the end. I also want to apologize in advance for some of the people who've seen my shtick before. In scrolling through the names on there, it's cool to see some familiar faces. So hey to you guys. But there were a lot of people who probably haven't seen some of this stuff before. So I'm going to keep things at sort of a 30,000-foot view, but if people want to dive in later, that's totally fine. A couple of disclosures. I have had some recent industry grants, nothing that has anything to do with anything we were talking about. I have done some consulting over the last couple of years. Nothing is relevant except I'll be mentioning some data that has come out from some of these companies, but it's all going to be cited peer-reviewed stuff. And that's about it. But I'd like to start here. Whenever I have these talks about looking at sleep in the context of health and society, I like starting here because I think it's important to remember what we're doing. So what is sleep? So we have these ideas about what sleep is physiologically. So a lot of us in the sleep research field, we see sleep as this, right? It's a set of processes that we can intervene on or sometimes go awry and that we want to better understand. That's our job. That's what we do. However, that's not what sleep is. This is what sleep is. So this is a quote from our paper in Science where they built a special issue around it. And I think this is the thing that I always try and keep in mind with everything that I'm doing, that sleep is not just a collection of biological processes. It's a non-negotiable biological state required for the maintenance of human life. It's really important. It's foundational to our biology. It's universal, yet we live in a society that often sees sleep as an unproductive use of time. And there's nothing worse than an unproductive use of time. And that, I think, is the problem. This discrepancy, this dissonance between our physiology and our society are what lead to most of our jobs, lead to most of the work that we do in terms of identifying and treating sleep problems and sleep disorders and studying how sleep impacts health. Because this has led to societal pressures that devalue sleep. And more recently, a reawakening to the importance of sleep health. And that's why we're here. And that's why we have all this data now and some great movement. Yes, sleep is related to health. This was a revolutionary slide in the first version of it, a little over 10 years ago, 10, 12 years ago, when I started doing this work. Now it's well, everyone sort of agrees on this. At the time, that wasn't true. But now, yes, sleep is upstream of a lot of different domains of health that are all interconnected with each other, which is why they're separate boxes, but joined within a common field. This is data from the consensus meeting a bunch of years ago where we came up with the sleep duration guidelines. And what you can see is there's general consensus that there is sort of a sweet spot for how much sleep should people be getting. This isn't the only dimension of sleep health. It just so happens to be the easiest one to measure in large surveys, which is why this is where all the data are. But there's more to it than that. So one of the things that I should talk about is the American Heart Association. So the American Heart Association is a very large organization. And they're also the largest non-government funder of research in the US. They're a very big organization. Heart disease is still the #1 cause of death in our society. And about a little over 10 years ago, over a decade ago, the AHA refocused their attention from just cardiovascular disease to cardiovascular health, because the thinking was that cardiovascular disease is a little too late. We need to think about what is cardiovascular health. And so they came up with a model they called it Life's Simple Seven. And the Simple Seven were 7 dimensions of health that if you had them all in order, then you should be in great cardiovascular health. And if any one of them was awry, it put you at increased risk. So the 7 were healthy diet, physical activity, weight and adiposity management, smoking, fasting glucose, blood pressure, and lipids. That was the Simple Seven. And as the data on sleep health was emerging, it was showing itself to be related to every single one of the Simple Seven in some way or form. But should sleep have been added to the Simple Seven? And so this was a study we did a bunch of years ago where we looked at nationally representative data, and we tried to operationalize the Life Simple Seven, or LS7, as you see on here, from nationally representative data, and look to see to what degree does it contribute to global overall ratings of health. I mean, it's not the best measure. I mean, really what we want is long-term cardiovascular disease. We didn't have that. I needed an outcome that wasn't confounded with any of them, but was still relevant. So we had overall health. What we did was we looked at how each of the Simple Seven was related to global overall health, and then we looked to see, is sleep related? Sleep duration, which was measured in the survey, was it also related to global overall health? And was the degree of association with sleep kind of in line with some of the others? And what you could see here in terms of the overlap in the model, the things that did a lot of heavy lifting were blood pressure and the history of diabetes. Those were 2 of the Simple Seven that seemed to be the most important. But a lot of the rest of them, the high-calorie diet was, you can see the data on that was sort of a washout, but that's complicated, I think, more by the American diet than anything else. But a lot of the other ones, you see a range of about 1.3% of the variance to about 2% of the variance at the top, except for the exceptions of blood pressure and diabetes. And what you can see is, well, how much of the variance is sleep duration explained? Well, about the same, about 18.5% on its own. So then, well, but if it's mostly redundant with what most of the rest of them, does it need to be added to the model? Does it contribute anything? And so the figure on the right shows what happens when you add sleep to the model of the simple 7 plus covariance. And what you get is an addition of predictive value into the model. And actually, it's actually a pretty big chunk of what sleep duration was doing wasn't already accounted for by the others. So you improve the prediction of health by adding sleep to the simple 7. And so this was a charge that I was involved with. I wasn't the only one leading this charge, that the simple 7 was incomplete without sleep on it. But I was one of the people who was shouting this from the rooftops. And then an amazing thing happened. The American Heart Association was revisiting the simple 7 and revising it. And so I participated in that task force, and it is no longer the simple 7. It is now life's essential 8, which I like better. Simple 7 was never simple to begin with. Essential 8 sounds way better to me. And now you can see it's all, the 7 remained and sleep was added to the model. So now sleep has equal billing with all of these as a measure of heart health. So, I mean, this is huge because not only does this help reconceptualize sleep health. This isn't sleep disorders. This is sleep health in general. This isn't sleep apnea. This is sleep health in general, conceptualizing sleep health as part of overall health and cardiometabolic health, as just as important as physical activity and lipids and all of these other things. This is great. The other doors that this opens is now, because of Life's Essential 8, there are mandates now that the American Heart Association is tracking all 8 metrics instead of just 7. Cardiology training programs are involved in all 8, not just 7. So this is huge. It's also worth mentioning that this is another image from our paper where we introduced this model, that there were the essential 8, which you could see in the top part of the 8. But there were 2 other things that we added. One was psychological health, and the idea was that was a spectrum along which all 8 of them interacted with each other. So psychological health wasn't one of the 8. It wasn't added to the list, but it impacts all of them. If you're in good or poor psychological health, it'll affect your weight, your blood pressure, your lipids, your sleep, your exercise, your smoking, for example. And then behind all of them is conceptualized to be social determinants of health, which I'm going to talk a little bit more about later. But these are the things that are all about where you live, where you're from, and what is your social and environmental context that dictate all of these things. So a little bit of a tour through some of the literature that got sleep onto the essential 8. I mean, there's a long history of habitual sleep duration being associated with chronic disease. So the 3 most common chronic illnesses in the US are obesity, hypertension, and diabetes. And here's some data where we looked at, this was from about 10 years ago, looking at a few 100,000 US adults, showing that you have this sort of J-shaped relationship where you have elevated risk associated with insufficient sleep, but also some risk associated with long sleep. We could talk about that. But this isn't just cross-sectional, it's also longitudinal. So here are some meta-analyses of longitudinal studies showing that insufficient sleep, defined as 6 hours or less, is associated with elevated likelihood of obesity, for example. So you're about 55% more likely to become obese. You're about 20% more likely to develop hypertension. You're about 30% more likely to develop type 2 diabetes, et cetera. I mean, there's a wide range of these meta-analyses, meta-regressions. I mean, these reviews have been out for a long time. I mean, this one's already 10 years old. There's many that have been out already that have documented this relationship. So it's not just that it's cross-sectional, it's that it's preceding the illness. One of the ways of thinking about this was about energy intake. So this is one that's very interesting to me, and we could talk about it more later in the Q&A if you're interested. But there were a number of laboratory studies that showed something really, really interesting, that when you sleep deprive people and you make them stay up late, they get hungry and they eat more. When you take people into the lab and you sleep deprive them, they gain weight, and a lot of it seems to be attributed to this overconsumption of calories after dinner. in the evening, nighttime snacking. Nighttime snacking seems to be, at least in the lab, a primary driver of potential cardiometabolic risk associated with insufficient sleep or poor sleep. When people are awake, when they're supposed to be asleep, they get hungry. This is in the context of the fact that you burn more calories when you're awake. So staying awake longer should burn more calories. Well, so what ends up happening is you end up consuming more, maybe to make up for the difference, and you overcompensate or something. This was some great data from Rupier St. Ange's lab showing that actually shorter sleepers did, on average, burn more energy than people who are getting the recommended amount of sleep, but it was only because they were burning more calories awake at night than they otherwise would have if they were sleeping. The thing is, because people are eating more at night, they're massively overcompensating for that. Another story that I want to tell really briefly is one about age. And there's a really interesting paradox when it comes to sleep, age, and health. So everyone knows this image from the famous meta-analysis of polysomnographic studies across the entire lifespan, showing that on average, sleep efficiency polysomnographically declines with age. On average, and this figure is not out of line with what you would expect to see for WASO, for light sleep, for other polysomnographic variables. It's just that this is the clearest. As we get older, sleep physiologically becomes shallower and more broken up. That's what happens. However, paradoxically, something else happens, and that's that subjectively, especially after you're adjusting for illness and other health issues, subjectively sleep improves with age. So this is an age gradient for perceived nights of insufficient sleep per week. And what you can see is excess nights of insufficient sleep sort of bottom out at retirement age around 65. Actually, the people who are reporting the most insufficient sleep are younger adults. And we've replicated this, and others have replicated this over and over and over again. There's another great study that just came out of one of the Scandinavian countries. I think it was Sweden. But I'm forgetting which country it just came out of, but they found exactly the same thing. We've also showed this relationship in terms of general sleep disturbance. We've shown it in terms of daytime fatigue. We've shown that in terms of sleep debt. We've shown it in terms of overall sleep satisfaction. We've shown it in terms of all kinds of metrics, as long as they're subjective experiences of the overall quality of sleep, it improves with age. So when you have patients who are saying, oh, I'm sleeping badly and it's bothering me, but that's just part of getting older, that's not necessarily true. Yes, sleep is, maybe you're waking up more. Maybe your expectations about falling asleep within 10 minutes, sleeping for 8 hours in a row with no awakenings, and then waking up feeling totally refreshed and ready to go for the day. Maybe that expectation is not consistent with what you would expect with aging. But if that's bothering you, this might be a solvable problem. And this impacts on health. So here's some data we looked at, some national representative data. We're looking at the interface of age on the relationship between sleep and BMI. Remember, I showed you how sleep is associated with elevated obesity. And here's that three-way relationship with all of these covariates in the model. Now, the great thing about this image is, two great things about this image. One, you can really show that the relationship between sleep duration and BMI changes across all these different age gradients. The other cool thing about this image is that it's in color and very sciencey looking. And so when we published it, we were very proud of ourselves. But the problem is, because only like imaging people get color figures. And so we got a color figure, and that was cool. However, it's really hard to read. So if I break it up, here's what it looks like. That if you look at it categorically, younger people need more sleep. So there's this kind of linear relationship. And then over time, the long sleep benefit goes away, and then a U-shaped relationship emerges, such that longer and shorter sleep is associated with elevated risk, partially because if you're a working age adult and you're sleeping 10 hours a night, and you don't have, like, you don't have, and you're employed, and you have no medical problems, and you're not a shift worker or something, like that's really unusual. So a lot of people who are longer sleepers are they oversleeping, or do they have some other condition that's leading to the oversleeping or excessive sleep? Um, but that's another question. But then you can see by the time you get to retirement age, all these lines are collapsing on top of each other, and there's no longer a correlation between sleep duration and BMI. And that makes sense. If you're an obese 70-year-old, the degree of obesity is probably not highly correlated with how much sleep you got in the last 2 weeks. It's probably more about, decades of accumulated risk factors. We see the same thing. Here's some data on hypertension, and any statisticians in the audience are going to have a seizure when they see this, because I'm just plotting stupid p-values, and p-values mean nothing. I know they mean nothing. It's fine. The reason I'm putting this on here is because we had almost 1 million people in this. It was about 750,000 people in this sample. So everything should be correlated with everything. I mean, the amount of overpowered analysis in something like this is high. So the question is, where are they, even with this huge amount of power, where was there nothing? I mean, if there's nothing, then that's really unusual. So where was there nothing? So there was no relation, you could see that there's a much weaker relationship between longer sleep duration and hypertension in younger adults. That sort of then emerges again once you start approaching and getting through middle age into older age, but then it sort of fades and goes away. The short sleep effect, though, also you can see that, after a certain age, unless you're in the most extreme short sleep group, of getting 2 to 3 hours, maybe 4 hours a night, there really isn't a relationship here. And it's, again, because if your lack of sleep was going to give you high blood pressure, probably would have done it already. We see the same relationship with perceived cognitive decline. So here's some data from US adults where people were asked, this is perceived cognitive decline, not actual cognitive decline. And so we looked at this U-shaped relationship, which again we see in both men and women, but you could see there's an age gradient, that the older you are, the weaker the relationship between how much you're sleeping and age, or how much you're sleeping and perceived cognitive decline, which again makes sense. If you're in your 70s and you're experiencing some perceived cognitive decline, there's many reasons why that could be the case. If you're in your 40s and experiencing perceived cognitive decline, there are much fewer reasons why that could be the case. And one of the more likely ones seems to be, are you getting enough sleep? So that seems to be happening. So everyone should be familiar with the classic study by Dong et al., where they brought people into the lab and had this dose response relationship to sleep loss. And again, everyone should be familiar with the fact that the really important finding out of this wasn't just the dose response relationship to cognitive decline, but also that the deficits were cumulative and that there was no real adjusting, even if people thought that they weren't getting worse. I mean, they know they were a little worse, but they thought after a few days they were just adjusting. And again, this has been replicated a number of times. There's a classic study in the field. Everyone should know this. But it's really hard to study this phenomenon in the real world. So we tried to do that by thinking, like, what is a real world task where we could get large numbers of survey respondents on this item that would get us the data resolution we needed to be able to detect something like this, where someone has a cognitive performance task that's mostly vigilance based. And so we came up with drowsy driving. And for example, we showed that people who were getting less sleep were more likely to be falling asleep at the wheel. And even if they said they never get insufficient sleep, they feel totally well rested every day, they're still more likely to be nodding off at the wheel, which shows that perceived or cognitive deficits due to sleep aren't mitigated just if you feel well rested and if you feel fine, which is really unfortunate, because a lot of times, in the press will say, a reporter will ask, what about people who are sleeping 5.5 or 6 hours and they feel totally fine? Should they sleep more? And then the correct answer is kind of like, we don't know. But statistically, whether or not they feel fine seems to be largely irrelevant. People may not know how impaired they are. This bears out into things like productivity loss, where when we looked at data at productivity loss, we showed that people trade sleep for work. Well, it's a bad deal because the people who were sleeping less actually got less done, and especially people who had insomnia were getting less done. And it wasn't just because they were tired. It was leading to problems across all these different domains of performance, and it was only slightly moderated by caffeine. You couldn't caffeinate this away. A little bit about mental health. So here's some data where we looked at the contribution of sleep-related different items on the ISI to both depression and anxiety symptoms. And the reason we looked at it this way was that this was really inspired by the work of JG, who after working in our group also went to work at Laval for a little bit. Shout out to the Canadians for that one. And what she had really illuminated was this idea that the daytime consequences of insomnia may be more related to the mental health correlation between insomnia and mental health than actually the nighttime ones. And that's sort of what we found, was that every single item on the PHQ-9 and GAD-7 was related to sleep problems, but they were slightly different. And for a lot of them, the daytime symptoms may have been more important. And it's really important to also mention that insomnia approximately triples suicide risk. And so does a lot of other types of sleep disturbance. And so I think suicide's a major public health problem. If it were an infectious disease, we'd be mobilizing for a cure or a vaccine or something. It's the second leading cause of death in the US in all ages between 10 and 34, and it stays in the top 5 all the way up to age 55. It's a major problem. And so we've been working on this issue quite a bit, and I'm not going to spend a whole lot of time on this, just to sort of tease a little bit that we actually think there's a common mechanism linking all of these different sleep disturbances to suicide risk, and that's what we're calling the mind after midnight hypothesis. So you can look up this review paper that spells this out. But really the idea is that when your brain is awake, when you don't want to be awake, when your body wants to be asleep, but your brain is awake. So you're at this combination of elevated homeostatic sleep pressure and a circadian nadir in cognitive and brain function. You get this perfect storm of not being your best self. You're cognitively and affectively dysregulated, which is why nothing good happens between 2 and 5 in the morning. This isn't just about suicide. We also have data coming out showing that's also related to food, why nobody craves a salad at 2 o'clock in the morning either. We think it's a lot of these common mechanisms that when people are awake, when their brain wants them to be asleep, there's a reason why bad things happen. So if you're interested in that, pull that up. So now I'm going to shift a little bit more towards some of these societal issues. We've been doing a lot of work on the US-Mexico border. Sorry for all the numbers on here. I didn't have time to make a more coherent figure out of this. But we've been showing that there are these really important links between acculturation, sleep, and stress and cardiovascular disease risk. Here's just some data on dietary intake showing that in Mexican Americans living at the border, sleep was related to things like emotional eating and uncontrolled eating. Here's some data where we're showing that it's not even just about sleep. It's also about some of these circadian factors in terms of interdaily and intradaily variability within rhythms and relative amplitude were all related to cardiometabolic risk. Chronotype may be important. So here's some data where we use UK Biobank to show short and long sleep associated with behavioral cardiometabolic risk factors. But when we did an interaction with chronotype, it totally changed the relationship where chronotype seemed to be an important moderator of those effects. And so that brings us to this idea of context. So it's not just about one dimension of sleep, it's about how that dimension of sleep exists within context. So here's some data where this was from African American middle-aged smokers in the Philadelphia area. So it's a relatively compressed group, but we looked at using a machine learning model to see what predicted actigraphic sleep duration and sleep efficiency when we looked at all the different variables in our model. And what was really interesting is if you look at the best contributors of unique variance to sleep duration, what you see is a smattering of social and environmental, behavioral, and physiologic variables. I mean, look at the first two. One was the safety of your neighborhood, and the second one was IL-8. I mean, like, so you couldn't have things that were more different from each other phenomenologically, but were both really highly related to sleep duration, showing that sleep is influenced by lots of different levels of things in the environment. Same thing with sleep efficiency. The highest rated factors were a combination of physiologic and environmental and behavioral factors. So some of this work also led to a really cool meta-analysis led by Teresa Aurora, looking at sleep and resilience. So is it just that bad sleep is related to bad stuff? What about good sleep related to good stuff? And what we found was that, yes, sleep duration is associated with improved resilience. And look at all these studies showing the relationship with sleep quality. And then when we only look at longitudinal prospective studies, yes, as sleep gets better, your resilience improves. So we have this issue where sleep health is a reflection of your environment, where you're coming from, who you are, and what you've done, and what's brought you to this point. But it also has these downstream effects on a lot of these different systems which we're going to talk about. So there's a quote I try and throw in every talk I do because I want everyone to read Simon Williams' Sleep and Society book, but it's an important reminder. Again, when we think about sleep as a set of physiologic processes, it's not. When we sleep, where we sleep, and with whom we sleep are all important markers or indicators of social status, privilege, and prevailing power relations. So why is it that people sleep the way they do? So here's an illustration of it from our paper in 2021 of the social ecological model of sleep health. I mean, we first introduced it in 2010, and we've iterated on it and modified it a bit over the years. This is sort of where it currently stands. So you have a sleeping person, and sleep exists in a context, which is why this person is sleeping in a context. You have these different domains of health outcomes associated with that, whether it's in the brain or in the body. We talked about that already. But what is upstream of sleep? So first you have individual level factors. These are things where if the person ceased to exist, so would they, things like your genetics, your age, your demographics, your thoughts, your feelings, your behaviors, what you do, what you think, things that exist inside of you, they determine when and how you're going to sleep tonight. However, the individual level is embedded within a social level. These are things that if you cease to exist, they would still be there, yet you're a part of them. It's where you live in your neighborhood. It's your job and your occupation. It's your family, your culture, your religion, your social networks. All of these sorts of things dictate the individual level factors to a large degree. Why do you have the thoughts and beliefs and priorities and behaviors that you do? A lot of these come out of factors at the social level. And this is important because if we're designing interventions that focus on individual level factors, because that's what's under people's control, yet the actual determinants of their sleep are at the social level, we're missing the boat. And no place is the field more glaringly off than how we deal with shift work. Shift work we treat as an individual level determinant of sleep and circadian disruption, but it's really not. I mean, so what is the standard of care for a patient who walks in the door and says, "Oh, I'm a shift worker and I can't sleep"? Usually what we say is, "Well, don't be a shift worker anymore." Oh, that solves all my problems. Or let's give you some stimulants to help you power through work so that you can be productive and not fall asleep at the wheel or whatever, but that's not really solving their problem. we're treating these as individual level factors, not as social level factors. And that's why I'm putting this on here. And so the social level itself is embedded within societal level factors. And the basic scientists love this one especially because if the individual was outside the cell membrane, this is way outside the cell membrane. This is globalization, 24/7 society, racism, technology, public policy, climate change. These are the things that your job, your family, your culture, your social networks, if they all cease to exist, these would all still be there. But think about the impact of technology and mobile devices and globalization and everything being online all the time. What is the role of that in how we work, how we live, what decisions we make into our own bedrooms tonight? And so this model, I really want everyone to have this in their mind whenever they're thinking about a person. This person in this picture is is embedded within this individual level set of factors, but that's embedded and all of these things are relevant. Oh, and also when the artist drew this, my instructions were draw a sun in the background and make it unclear as to whether the sun is rising or setting, because that's supposed to illustrate the circadian process that's separate from all of this and existing in the background of all of these processes. That's not, so all of these are in the context of circadian rhythms and the physical environment. So how does this bear out in terms of data? So we looked at hotspots and cold spots of insufficient sleep around the US, showing that it's not really random. It's actually linked to a wide range of social environmental factors can predispose a region to being a hotspot for poor sleep health. One area that we focused a lot on are sleep health disparities across race ethnicity groups. So here's some data where we tracked NHIS data. This is nationally representative data from the US for the CDC. Over all the years it was gathered from the 70s until the data set where we were looking at came out around 2010, so 2009. And what you can see here, these black-white differences in getting the recommended amount of sleep. First of all, they're present. And they are really, really parallel. They're not changing. They didn't seem to be getting any better or worse. But we then followed this up with a more recent analysis, picking up where we left off and then taking it into sort of present day. And what we find is it's actually getting worse. Actually, everyone's getting worse. On average, sleep duration is dropping in the US population, but it's dropping differently across groups. And there were two groups in particular where it was dropping the most, and that's Blacks and African Americans in the US and Mexican Hispanic, not non-Mexican Hispanics and Latinos, but only the Mexican Hispanic population was dropping faster than any other group. And you can see that on the left-hand side, that black-white disparity is getting worse. And whatever there was a benefit to sleep to being Mexican American in the US, and look, it's now gone. That gap is now closed. And if you can, and we looked to see what was driving it, and it was the elevated rates of habitual short sleepers. It was short sleepers on the rise in both groups. And the reason this was alarming was in this paper, we also showed that this change was explaining differences in disparities in cardiometabolic disease. The differences in sleep loss were explaining the disproportionate gains in, I think it was like hypertension, prediabetes, and weight gain, if I remember correctly. But you check the paper to see which outcomes we were looking at. But but we showed that actually this was having an impact on health disparities. So why is that the case? So here's an image that tells the story about sleep health and socioeconomics. So why is sleep health related to socioeconomics, especially when you can't buy sleep? People tried, you can't. It's not really for sale, even though if anything, people are sort of selling their sleep for more work, but that's a whole other story. But how do all these dimensions of socioeconomics impact sleep health? Well, income and wealth doesn't buy sleep, but it affords services, it affords control, it affords choices, and it gives you time, and Education doesn't just, teach you about that sleep is important. Look at any doctors who aren't getting good sleep to find that education doesn't teach people that sleep is important. But what education does do is it provides you better access to jobs that usually gives you more control over your ability to sleep, and you're less likely to be working shifts in multiple jobs. Shift work prevents your ability to get good, healthy nighttime sleep. Working more work hours, same. Some people have to get up very early to get to their first job so they can be done in time to get to their second job. People with lower socioeconomic status are more likely to be in unsafe environments. And they're more likely to experience stress and anxiety and hyperarousal. They're more likely to get injured, which basically disrupts sleep, could be long term. And they're just more likely to be exposed to all kinds of environmental and other toxins that can be metabolically active and impinge on sleep, whether it's chemical or just light pollution or noise pollution and things like that. But I also want to stress that it's not just that socioeconomic disadvantage leads to poor sleep health, that you're set up for worse sleep. It also goes the other way too, and there's a number of mechanisms that drive this two-way relationship. For example, decreased control and autonomy. I got to credit Lauren Hale for this idea of autonomy over time being a big link between socioeconomic disadvantage and poor sleep health, but it goes both ways. Everything on this list is made worse by socioeconomic disadvantage, can lead to poor sleep health, is made worse by poor sleep health, and can lead to more socioeconomic disadvantage. Financial stress, housing, food, employment, health related, psychological stress, depression, unhealthy substance use, whether it's stimulant overuse, alcohol use, smoking, etc. Illness and debility, and injuries and accidents. All of these things help this go both ways. So our group in particular has been really interested in this idea of control over sleep. We developed this 4-item index of sleep control that we've been throwing in all of our trials, because if we're doing a sleep health improvement program, I mean, people don't say, oh, I'm not getting the sleep I need because I hate sleep. It's because I don't have time, or I can't, or something that they feel is outside their control. So if we can help people increase their sense of control, we might be able to make more of a difference. And if we don't increase their sense of control, we're wasting our time. And so we've been inserting this into all of our studies, and it's showing to be one of the most useful new measures that we've been using. And just in the validation paper, we showed that it's really related to pretty much every sleep related outcome you want to look at, but not necessarily an indicator of sleep health, for example. But it's an important process. Other interventions. So this is going to the last phase of the talk where I'm like, well, what can we do about it? Well, some solutions are relatively simple. So there's all kinds of data from blue blockers, and everyone's using these things in terms of blocking out circadian active light at night. To what degree are they helpful? There's disagreements about this, but there's a number of papers that show that overall they probably help protect sleep. The only problem is all of the blue blockers used in this study, each study only used usually one, and they're usually well vetted. The problem is when people are out there buying stuff, there's all kinds of stuff on the market. So what we did is we did an analysis of 50 different products on the market and looked at how they performed under controlled conditions, and essentially showed that some are better than others. And then you could read the paper to learn a little more, but essentially for what's on the market now, if your lenses are orange or red, you're probably fine. If your lenses are any other color, it depends on how you're using them, but the clearer the lens, the less likely they're actually doing anything useful. So in terms of behavioral changes, so we're very interested in this idea that why would people make behavioral changes to their sleep? Because one thing we know is that human behavior is complicated, and what drives behavior is not always what we would expect. So the thing about sleep is, a lot of people listening to this are sleep people, they're sleep researchers. If you go to any group and they say, well, what do you do? And they say, I study sleep. And then And then everyone has a story, right? Everyone has some story about sleep. And then if you say, oh, well, do this or whatever, a lot of people say, oh, I can't because, or like, oh, like I've had these problems for a long time, or like, well, I used to, blah, blah, blah. And the thing is, I think a lot of people are starting to get to the point where they care about sleep, but they're not really willing to do much about it. And I think, why is that? So for example, so we did these focus groups in Philadelphia. We were asking people, so let's say I told you that sleep was important for blood pressure. Would you believe me? Yes. Would you do anything about it? Would you change your sleep because of it? No. Why not? Well, I believe you that it's related to blood pressure because lots of things are related to health and blood pressure. It probably causes cancer or something. But if I really cared about my blood pressure, I also need to exercise more and eat better. And I'm not doing those things. And those probably impact my blood pressure even more. So, if I'm not willing to do that, I probably shouldn't, probably, as long as I can get to work okay and get home and I'm fine, like I'm not going to do much about my sleep. I don't really see it as a big problem, for example. So I was really interested in what actually would lead people to make changes. So we studied this, and we asked people whether they believed that sleep was related to things like sleepiness, sleepy driving, weight, heart disease, cholesterol, blood pressure, moodiness, energy, sex drive, missed days at work, worse work performance, memory, diabetes, and daytime tiredness. And we looked at it wasn't just and the ones that are sort of glowing, that's because I didn't want to have asterisks all over the place, but these are all the ones that were statistically significant. And we also showed that this is controlling for total sleep time and even insomnia symptoms, because, well, obviously the people who were having more sleep problems probably believed it was either more important or less important, so we controlled for that. And basically you see is people, except for sleepy driving apparently, um, people generally believe that sleep is important for things. But my guess is if you think it's important for your heart, you also think it's important for your cholesterol. So when we did a stepwise analysis, really there were two variables that emerged. One was moodiness, and number two was weight. Those are the things that I guess people might be more willing to make changes in their sleep in the service of. And I'm going to just very quickly talk about a few other interventions we've done. So Project Rest was a study we did in college student athletes who have no time for sleep. Yet by focusing not on telling them to sleep more, but just by improving their ability to control elements of their sleep, like stimulus control and sleep tracking and things like that, we actually increased their sleep time by over an hour, mostly by increasing their time in bed by about 40 minutes and increasing their sleep efficiency. This is a non-clinical sample. Another approach is using people's data to give them tailored feedback. We're calling this systematic sleep time extension. And so we have a published pilot study where we were able to increase time by almost 2 hours in people without even, this wasn't motivation. This was, okay, based on your data, do this. Based on your data, do this. We used that along with an insomnia treatment in smokers, showed that we can not only increase their sleep time, but we could also improve quit rates for smoking, which shows that you could use sleep to improve other interventions because of how sleep is related to all these things. Here's a study that just came out from our group looking at an online sleep coaching platform. So this wasn't a clinical sleep intervention. This was a real world, no control group. This was just a proof of concept study of people who downloaded and used a sleep coaching app, showing that depending on what they walked in the door with, because again, this was just regular people, they showed on the left is improvements in WASO and on the right is improvements in total sleep time, basically showing that actually the worst problems you had, so people who had less than 30 minutes of WASO didn't really change their WASO. But people who had low sleep efficiency or high amounts of WASO, it got way better, for example. So you can increase total sleep time, you can reduce wakefulness during the night with just subclinical sleep coaching from non-professionals. Some of the sleep technology is really simple. This is one of my favorite studies from the last year or so, where just a simple mask worn at night provided great improvements to sleep and next day function. So you don't need to have complex technology. And you don't even need to have individual level interventions. So this is some great work from Susana Martinez at UCSF, showing that food pantries can be a great system level intervention for improved health via improved sleep. People are sleeping better if they can get access to healthy food, and that leads to improved health. So, you can intervene on these different levels. So take home messages: sleep and circadian rhythms are fundamental aspects of our biology, and thus impact a wide range of physiologic systems, leads to impacts on health, quality of life, and longevity. The causes are varied and extend into social and environmental influences, and changes can occur on the individual level, but also social. So, quick plug for our lab. Thanks to our funders. Check out our website. If you a quick plug for our we have a weekly seminar that's live and free on Thursdays. Free continuing education. You can read about it on our website, and thank you very much.
Wonderful. Thank you, Dr. Grandner, for that very comprehensive and interesting talk. I just like to also respectfully acknowledge in your last slide, I think is a nice lead-in. I missed this in the beginning, to acknowledge that the University of Arizona is on the land and territory of the Indigenous peoples, which is Arizona's home to 22 federally recognized tribes. Yeah. Tucson being home to the Ojibwe and the
that's the O'odham and the Pasquayaki.
Okay, thank you. And committed to diversity and inclusion, the university strives to build sustainable relationships with the sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So I'd just like to take a moment and see and remind folks of the use of the Q&A chat function that's at the bottom of their Zoom screen to ask their questions. I think we have probably 5 or a little bit more minutes per question.
As they filter in, I can actually answer questions pretty fast. So the faster you type them in, the faster I can get to them. Okay, so the first one on here is, do we need expensive blue blockers with yellow or orange sunglasses? The data showed that most of the difference was color-based. Within the orange ones, some were better than others, but it looks like at this point, most of the differences were, that's why our figures are actually divided by color. You can look at the paper and get the full list of every brand of everything we looked at to get their actual values. I believe in transparency. But yeah, I mean, for now, you kind of only really need, if you've, we as a joke, sort of not really as a joke, but because we thought it was funny, I found on Amazon these like little kid heart glasses that were just plastic, and they came in a bunch of colors. There was an orange one, a pink one, a red one, and a yellow one. So we added those. So a few of them are that. They're these like $5 and they performed great as if they were orange or if they were red. So it doesn't need to be expensive to work well. Some of the nicer ones did perform slightly better, but you're talking about, the difference between that and like a yellow one was worlds different. Okay, so the next one. Okay. My email is just, I'm easily Googleable. You Google my last name, it's a very unusual last name. I will be the first thing that probably comes up. And if you Google my first and last name, you'll find me easily enough. Let's see.
I might just also point out that Jean-Philippe Chaput has his hand up.
Oh, awesome.
Jean-Philippe, do you want to unmute yourself?
Yeah, sure. Thank you. But Michael, you can answer other questions too. I'm fine as well. Good to see you. Thank you for doing that and putting sleep on the map as well. A quick question for you because time is running. About the start of your presentation, seeing sleep as a waste of time. We hear that a lot. And I know many of my colleagues, even my neighbors, they say, okay, I move and I eat well. So I check those 2 boxes. So why should I care about my sleep? So always seeing sleep as it doesn't care if the other behaviors are okay in your life. So how can we change the narrative? So this norm of seeing sleep as a waste of time so that people prioritize a bit more sleep not over that and exercise, but in addition as a package. And I see that it's less important for many people than eating well and moving more for their health.
Yeah, I mean, you've done some amazing work on the Canadian side on this. I mean, I turned to I ended up citing a lot of your guidelines that you led on this issue about sleep being not sedentary time, but important, especially for kids and people developing. I think honestly, I think one of the things I tell patients is, well, even if we're not where you want to be yet, if you're going in the right direction, let's just keep going. As long as we're going in the right direction. I think we're going in the right direction. I mean, you remember, and like we all remember, 10 years ago, this wasn't on, it was, we needed to convince people that sleep was important, that was related to stuff. So then we started publishing as much as we could. And then we're starting, and right now people are starting to get to the point where it's okay and they can give themselves permission to get good sleep. And I can speculate on a bunch of reasons why it's happening now and it wasn't 10 years ago. I think it takes some time to permeate. But I think let's just keep reinforcing good behavior when we see it. I think we're moving in the right direction. That the message has to be, give yourself permission to sleep, because whatever it is you care about. So this is what I do when I try and talk to a community group or an industry group or something. Instead of me telling them, well, it's related to all these things that I care about, I've tried to figure out what they care about. That's why I'm looking at things like work productivity, that sleeping less, actually you get less done. Just because you're spending more time working doesn't mean you're getting more done and you're advancing in your career more and earning more money. You're actually doing less. And you're making yourself more likely to get injured, and you're more likely to have to go out on disability anyway. So like, why not? What do you have to lose? And so what I'm trying to do is systematically, at least in my work, is find the actual pain points, not the ones, not necessarily NIH's pain points, those two, but real people pain points, target those as specifically as I can, while at the same time develop interventions that real people can actually use. So it's like this whole thing about everyone needs to put their screens down an hour before going into bed. That's the dumbest recommendation ever because nobody can follow it. So what you end up doing is, it's like telling everyone they need to eat 5 to 7 servings of vegetables every day, or else it's not even worth trying. Like anything helps.
Yeah.
And so if we can help people go in the right direction without needing it to be perfect, I think that'll make a change. Okay, cool. So the next question on here, oh, sorry.
Oh, I was just going to say that's a great lead into some of the questions
Yes.
in the Q&A. And Rebecca, I think we're okay to continue on if Dr. Grandner's.
Yeah,
Yes,
I'm okay.
absolutely.
I actually again, having my own seminar, we go over every week. So I sort of budgeted the time. And it'll be on the recording forever, so it'll be fine for anyone who wants to access the recording. The limited attention sleep in public health and policy campaign. I think part of it is also the same thing with, just like with doctors, lawyers and legislators also don't like sleeping. And there's this attitude in that population. And I think, we need to make more inroads in terms of helping them see that it's worth their time. And that so when I was a postdoc, I heard this great story about the history of legislation around Alzheimer's, and about how, like, yeah, we see Alzheimer's disease research as an inevitability, and there's all this research being done. They're like, but if you were here 20, 30 years ago, when I was, this tall, if you were there, I was there, and I remember no one wanted to fund Alzheimer's research because from a lawmaker's perspective, these were a bunch of old senile people in homes who don't vote. So there wasn't a whole lot of attention until everyone started getting older, and they're like, oh shoot, that could be me. And then all of a sudden the floodgates open in terms of research on Alzheimer's disease because nobody wants it. And I think the lesson there for me was that the change didn't just happen at the top. It wasn't just about lobbying Congress or whatever to make the policy change. You want to make the policy change inevitable by changing the conversation on the ground, where if they don't make that policy change, they look stupid and out of touch. You want everyone to be clamoring. This is what they're doing with the school start times legislation, which I think is working, is make everyone clamoring for this, make it a no-brainer, make it an easy win for any kind of legislator, and then they'll do it and then they'll see it for themselves. But I believe in bottom-up level change. And I think the reason we're not seeing it is our field is so top down, we focus at the top. And I think that's important to hammer, but I think we should be devoting our attention to do as many press releases on every study we can, talk to every reporter who asks us to, you know, speak to as many groups who are willing to listen to us ramble on about the stuff we care about, and answer as many questions as we can in as relatable a way as we can, so that people start taking this home and looking at what they're doing and what their parents are doing and what their kids are doing, and it becomes part of their life, and then it becomes a no-brainer. Then it becomes inevitable. That's my career goal, is to make sleep health change at a societal level, get to the point where it's sort of inevitable that it's going to happen. Anyway, okay, so that's that. Is there a real way to help shift workers sleep without taking them out of their job? Yeah, so it's sort of like, it's all about, well, you know, if you talk to circadian people, there's much better circadian people than me on this. But when I talk to circadian people, what I hear is, well, is shift work as bad for you as smoking is? Maybe, maybe not. But the fact that that comparison is even being made, I think, is shocking, and would shock people who didn't know that the data showing that shift work leads to diabetes and cancer and all these sorts of things, because, you know, every cell in our body is built on clocks, and when you're shaking up these clocks like a snow globe every week, like, it leads to dysregulation. And I think, to some degree, unless we can find a way to rapidly shift people, we're not going to fix the problem of shift work. It's just the Industrial Revolution made it inevitable. That's a societal issue. So now all we can do is cushion the blow as much as we can, until we can find new solutions to maybe more rapidly shift people, or accommodate people a little better with alternate schedules, which is the one good thing coming out of globalization in 24/7 society. But that's a whole other can of worms, and I'd be happy to talk offline about all my crazy ideas about that. Oh, how do we draw on Thursdays? Yeah, seminar. It's fun. I don't know if any of you guys normally go. We get a whole bunch of people coming. We're in a session right now. We're focused on aging. And so we've got a bunch of talks in a row on aging related stuff. But yeah, check out the website. It's, you know, it doesn't cost anything, and it's a fun group. So yeah, if anyone throws anything else, oh, there's something else. Is there a special program to become a circadian person? I don't know, but if you find it, I'll sign up. So like, when I was an undergraduate, I worked in Michael Perlis's lab at the University of Rochester before he moved back in the day, and it was very EEG focused. And then in grad school, my advisor was Dan Kripke at UCSD, who was a sleep and circadian person. I had no idea what circadian rhythms were, but I left that lab knowing a lot more. I mean, I'm not really a card carrying circadian person. I think the test is, if you can draw the molecular clock and all the arrows and the circles, I think they let you in. I haven't passed that test yet. I can't, that's not as much my world, but I can still think from a circadian perspective a little bit. And I think that, the more we integrate sort of the sleep and circadian fields. I mean, these are all fundamental things. They're fundamental properties that are not separate from each other. They sort of grew together. And I think looking at them in isolation is problematic. And I think we should be playing well together. I don't know why we don't. I mean, I enjoy working with everybody, so I don't understand why these like groups get siloed. Besides just the fact that, just like everyone else, they get busy and focused on things. But I think we need to have more of these conversations. The circadian people need to be telling the sleep people what they've been doing, because it's some really cool stuff, especially on the genetic side, where they've been making huge advances where the sleep people haven't so much, because we've been hitting walls. Where the sleep people have been making huge advances in human research and population health, where the circadian people have been hitting walls. And so I think there needs to be more communication. Cool. Awesome. Any final questions? Or anything else I could throw out there?
There's a shout out that the behavioral sleep medicine seminar is fantastic. So again, that link is in the chat. We probably can include that in comments section when we post the recording. Yeah, if there's no other question, Alzana has a question.
Okay.
As a clinical psychology student,
Yes.
I see sleep training really lacking. in their program, and thinking about having healthcare providers ask more about sleep and sleep health is a very important part of making sleep health more commonplace, like diet and exercise. And how do you think that lack of training is influencing sleep health? So I know you mentioned.
I think it's huge. I mean, the American Academy of Sleep Medicine has the great idea of this just one question campaign that they're doing of like, healthcare providers, just ask one question. How's your sleep? And then take it from there. Like, even if you don't know exactly what to do with it, at least open the door. The fact that the AHA now has sleep as part of the LE8, we can now go to every cardiology program and say, okay, are you measuring blood pressure at every visit? Are you measuring lipids? Are you having annual cholesterol screenings? Are you checking fasting? Are you do you ask about smoking every time? Do you get height and weight every time? Okay, do you ask about, no, you don't ask about, well, you got all the other 7, well, you're missing one. You forgot one of the 8. So you could do that now. But really, the SBSM has been great in terms of opening up board certification to people outside the US who aren't even clinical psychologists. You have expertise in behavioral sleep medicine, you can, and you're licensed, you can get board certified. And they're working on a CBTI alone certification. But show me where else in all of psychology or healthcare, like as broad as it is, where you have a condition that, like insomnia, that is this prevalent, that is this reliably tied to outcomes that people care about, that has a treatment in CBTI that is this well studied, that is this well understood, that is this well recommended by every organization that has a recommendation, that is this easy to implement, that is not rocket science, and yet is not part of basic training. In like every clinical psychology program, this should be part of the curriculum. And for a while, I was sort of advocating this until I realized that was like talking to the programs was not going to get anywhere. The programs are going to teach what the accrediting bodies require them to. And so the APA in the US is a disaster in terms of getting anything done. Like, it's built to be unchanged. Like, getting something approved through so many layers of committees, like I sort of am giving up. But maybe the Canadian system can lead here, where we just need to change the accredit. Like, I had to learn the stupid Rorschach still, because that's still on the list of things that are on the licensing exam, and therefore also on the clinical psychology training guidelines. I had to learn the stupid test, even though my instructor at the time told me this is an invalid test, never use it, but I'm required to teach it to you. Like, that's the state that things are in. As opposed to something like CBTI, there's no reason why CBTI has to be sequestered in the halls of behavioral sleep medicine. It's not that hard. I can do CBT for depression. I don't need to be a depression person. Like, it's just a thing you can learn how to do. So I totally agree. This is, sorry for the soapbox. This is clearly a triggering thing for me, that like it's a huge opportunity that we just need to find someone who sits on the right committee, who knows someone who sits on the right committee, to make the proposal, to get it passed, to throw it on the list of things that get covered on a licensing exam, and then people will learn it because they have to.
Yeah, that I think that's a great idea. Maybe we should be also looking at a little bit. We probably have a little bit more manageable things. Thanks, Carrie. So with that, I think we could have a whole session just Q&A with Michael. But thank you so much for this presentation today, and thank you for the questions, the people that provided the questions. It was really great, except I didn't get to ask mine, but maybe we'll do that later. Just a reminder, the webinar recording will be available on the Canadian Sleep Research Consortium website shortly, which is researchsleep.ca, or my pronunciation is going to be bad, rechercheSommeil.ca. So thank you.
And you're Canadian.
Well, I know how to say chicken. The grade 12 French only goes so far. And rock voisine. But thank you again for your contributions, and happy to wrap up now, and just a reminder to people that the recording will be on the website. So thank you for everyone for attending, and hope you have a great day.
Have a great day. Take care.
Thank you. Thank you, Elizabeth and Michael.